Okay, so now we're going to go over all of the hepatitis viruses, which if you can remember, there are 5 types, from A to E. First, let's start with the general things. All of them are RNA viruses, except for hepatitis B. 2 are transmitted by the fecal-oral route, namely Hep A and Hep E, while the others, namely B to D, are transmitted sexually, maternal to fetal transmission, or by contact with blood. So, let's talk about A and E first. I like to remember that vowels are for bowels. A and E are transmitted by the fecal-oral route. Hepatitis A is often asymptomatic or subclinical and will present with acute, mild flu-like symptoms, jaundice, and watery diarrhea. The infection is self-limited and does not progress to chronic hepatitis or hepatocellular carcinoma. An HAV vaccine is one of the vaccines recommended for all children. It is available for patients with chronic liver disease, especially those with hepatitis C, travelers to high-risk countries, or those in high-risk communities. Looking at hepatitis E, the virus is serologically distinct from hepatitis A, but it closely resembles HAV in its incubation and clinical presentation. It is also self-limited, but can cause fulminant hepatitis in pregnant women, leading to sudden mortality. So, if you see a question about a pregnant woman with hepatitis E, think Hep E. The baby is not happy, if you get my drift. Alright, now let's talk about the others. Let's start with Hep C. Hepatitis C is mainly acquired through IV drug use or blood products such as transfusions. It can be sexually transmitted, but not as easily as Hep B. In fact, heterosexual couples where one has Hep C don't need to use barrier contraception to prevent infection. I've written down the statistics here for chronic infection. In the case of Hep C, more than 50% of infections result in chronic infection. This is opposed to Hep B, where only 10% result in chronic infection. In other words, HCV is a much more serious infection than HBV. Persistent Hep C infections may progress to chronic hepatitis, cirrhosis, and hepatocellular carcinoma. There are many C's there: chronic, cirrhosis, carcinoma, and carrier. It's a good thing that hepatitis C has a C in it, isn't it? One thing to remember with hepatitis C is that the virus is genetically unstable because it has poor proofreading. It lacks the 3' to 5' exonuclease, making it prone to genetic mutations. Next, let's talk about Hep B. Hepatitis B is a more complicated virus. Let's take a look at this image showing the Hep B replication cycle. Let's start here. After infecting hosts, the partial double-stranded DNA genome is completed by a viral DNA polymerase that creates a fully double-stranded genome. The host cell's RNA polymerase then transcribes viral DNA into viral mRNA. This viral mRNA is used to make viral proteins and to regenerate the partial double-stranded DNA virus genome. The partial double-stranded DNA genome is reconstructed using the virus's reverse transcriptase. So, that was a mouthful. We're going to go over that carefully. You start off with partial double-stranded DNA, which is completed to form double-stranded DNA via the HBV polymerase. You then make a positive single-strand RNA template using the host cell DNA-dependent RNA polymerase. Then, using the HBV-encoded reverse transcriptase, you make double-stranded progeny. The viral mRNA is also used to make the viral proteins. If this is confusing to you, just go over this again. It is actually relatively simple and makes a lot of sense. Going back to the characteristics of HBV, it is transmitted through blood transfusions, sexual contact, and placentally. Acute infection results in jaundice and fever. Most, up to 90% of infections resolve, but chronic infection may result in an asymptomatic carrier state. But there is a risk of developing cirrhosis and/or hepatocellular carcinoma, which occurs via integration of the Hep B virus into the host genome and subsequently acting as an oncogene. Hep B is important to remember because it is the most easily transmitted infection in a finger stick. An unimmunized healthcare worker who gets pricked needs to immediately get the HBs antigen vaccine and HBIG. Alright, coming to our last hepatitis virus. Hepatitis D virus is a defective virus that requires hepatitis B surface antigen in order to replicate. Transmission of HDV can occur via simultaneous infection with HBV, known as co-infection, or via superinfection, which is when HDV infects an individual who was previously infected with HBV. So, if we could eradicate hepatitis D from the world, how would we do that? You're exactly right. It would be by vaccinating and getting rid of hepatitis B. Okay, let's get more into the nitty-gritty of hepatitis. We're going to review some of the serologic markers we will encounter. I would say that this is a very high-yield topic and something that I recommend you go over several times until you understand it. If you are shaky about antigens and antibodies, go back right now and review this in the immunology section. So we're going to start with hepatitis A. For hepatitis A, you can have two types of antibodies. It's relatively simple, IgM or IgG. IgM antibodies are the first class of antibodies to be produced by the body and indicate acute infections. IgG antibodies are made later after class switching, so their presence indicates previous infections or immunization. Therefore, as a rule of thumb, remember that IgM equals acute and IgG equals previous infection and immunity from reinfection. The presence of anti-HAV antibody can tell us whether the patient has active hepatitis A or was previously infected with HIV. Does this make sense to you? Anti-HAV IgM antibody is the best test to indicate a patient has active Hep A, while anti-HAV IgG antibody indicates that the patient had a hepatitis A infection and or prior vaccination and will protect this patient from being reinfected in the future. So that's relatively straightforward. Now let's move on to the markers for hepatitis B. Let's start with the structure of the hepatitis B virus particle. There are key parts of the virus particle which are antigenic and to which you can form antibodies. First, there is the viral genome or DNA, as well as the polymerase. So actually, let's start off with the DNA and the polymerase, to which you can actually not form antibodies or antigens. In fact, it is to the core or the capsid to which you can form antibodies. Then you have this envelope with its surface proteins to which you can also form antibodies. In other words, there's the capsid and the envelope to which you can form antibodies. Let's move this image to the side for now so you can refer to it. Really cool animation, huh? Let's go through the serologic markers one by one. Hepatitis B antigen is the surface antigen found on HBV. It is a glycoprotein that is found in the envelope component of the virus structure. If you see HBs antigen in a patient's blood, this indicates the patient has the hepatitis B infection. Presence of HB surface antigen for greater than 6 months indicates chronic infection. If you were to see that the patient had antibodies against the hepatitis B surface antigen, then the patient has immunity against hepatitis B. This can occur in one of two ways. Either the patient was vaccinated against hepatitis B, or the host formed antibodies against the HBs antigen and recovered from the infection. Next, we'll look at the core, or capsid, as I showed you before. The hepatitis B core antigen is an antigen found inside the core of the HB virus. You cannot detect core antigen in a patient's serum. Antibodies against the HBc antigen tell you whether the patient has an acute or chronic infection. So question, which type of antibody would indicate a recent HBV infection? You're right, as we already discussed, the presence of HBc antigen IgM antibodies would indicate an acute infection. IgG antibodies, on the other hand, would indicate immunity. Sometimes the only serologic marker you might see in a patient's blood is anti-HBc antigen, and this indicates the patient is in the window period of the disease, which we'll come back to and discuss in a moment. Note that the vaccine against HBV contains only HB surface antigen. This induces HB surface antibody. There is no antibody to the core antigen because the vaccine does not contain that protein. However, people who are initially infected with HBV will form the antibodies to both the surface antigen and the core antigen. So we're making a distinction here between people who were vaccinated against hepatitis B and those who were primarily infected. Finally, we're talking about HBe antigen. It is another antigen found in the nucleocapsid core of the HB virus. HBe antigen correlates with how infective a person is. If a patient has HBe antigen in their system, it indicates that infectious HBV is present in the blood and therefore the patient can be a source of infection to others. However, in contrast, the presence of antibodies against HBe antigen indicates a low transmissibility. Okay, so let's try to put this together. Take a look at the graph here showing the timeline for when certain serologic markers will develop in the blood. You will see here that initially when the patient is infected, they will develop high levels of HB surface antigen. You will also see high levels of HBe antigen because the patient is highly infectious. Over time, the patient will develop anti-surface and anti-E antibodies. I've circled these for you here. The anti-surface and anti-E antibodies indicate resolving infection and low transmissibility. Additionally, the patient will develop anti-core antibodies. Initially, these will be IgM when the infection is acute, and then IgG as they resolve the infection. I've written that out for you here. I think the main thing you should know is that around the time of 5 to 6 months after exposure to the HB virus, there exists a window period. What is the window period? It is when a host has been infected by HBV and is successfully clearing the virus. Even though the host is forming the anti-surface antigen antibodies against the disease, they are not detectable in lab tests because the antibody is bound to the large amount of surface antigen. It is only after the HB surface antigen is cleared that the antibodies become detectable in the lab test. Think of it as a balance between the antibody and antigen, which prevents either of them from being detected. So basically, in the window period, the only serologic evidence for HBV is the presence of HB core antigen antibodies. However, you might see high levels of HBe antibodies in the window period, which makes sense. This indicates low infectivity as the body is resolving the infection. So, now we're going to go through this table which I've made for you, which tells us which serologic markers to expect depending on what type of HBV infection a patient has. Start with a patient who has acute HBV. What serologic markers might you expect? Well, they have the infection, so they must show HBs antigen in their blood. The infection is acute, so which antibodies will they have? They will have IgM core antibodies. Since the infection is acute, we will expect the host to be highly infective since he or she hasn't had time to develop antibodies against HBe antigen. Therefore, you will see HBe antigen in the blood. We've already discussed the window period, but let's go over it again. In the window period, anti-core antigen antibodies are the best marker of Hep B infection. They may also have the E antibodies indicating low transmissibility since, as we said, they are in the process of resolving the infection. In a patient with chronic HBV, they will have surface antigens and no surface antibodies. This is because they have not yet resolved the infection. In other words, they have a chronic infection. They will have core IgG antibodies since this is an indication of chronic infection. Now, their HBe status will depend on how transmissible they are. In other words, whether they have low or high infectivity. High infectivity means they will have HBe antigens, whereas low infectivity means they will have the E antibody. Now, someone who recovered from the infection themselves will show evidence that they at one point had the infection with the presence of IgG core antibodies, anti-HBe antigen antibodies, and anti-HB surface antigen antibodies, which are IgG. These are the protective antibodies. This is in contrast with someone who has been immunized. Someone who has been immunized against HBV will have only the surface antigen antibodies in their blood. They won't have the other protective antibodies you can see in someone who has recovered. Time for another flash quiz. To determine whether a patient has Hep B, I will order these serologic markers. I'd like you to name 3. If I were you, I would order surface antigen, core antibody, and E antibody. Remember that the core antibody is the only marker seen in the window period. You may not see surface antigen in this time. The E antibody is an additional one you can order to see whether the patient is highly infective or not. So that was a lot of information about all of the hepatitis viruses. Hepatitis B in particular has a lot of information about the serologic markers, and it all depends on whether the patient has a chronic infection, an active infection, whether they were immunized, how transmissible they are, etc. I would go over the table that I had on the other slide one more time just to make sure that you fully understand all of the complex situations that can occur in the situation of hepatitis B.